Okay, I think we'll start. I guess more colleagues may join us as we speak. So welcome to our Institute for Mental Health seminar series today. And we're delighted to welcome Professor Liz McDermott. So Liz joined the university last term. We're delighted to have her as our chair in Mental Health and Society and as the deputy director of the Institute for Mental Health. So really pleased to hear about Liz's research today and how it impacts on youth people's mental health. Liz is going to talk for about 30 minutes. Then as normal, we'll have a bit of time for Q&A, which I'll chair. So please post your questions in the Q&A and I'll facilitate giving those to Liz and she'll respond verbally, I guess. There might be bits of a chat as well around the topics. And then we'll probably close about sort of 10 to 2-ish. I hope to have time for a good discussion around the themes that Liz highlights in the talk. So Liz's title is What Works to Support LGBTQ plus Young People's Mental Health, an Intersectional Youth Rights Model. Thank you very much, Liz. Over to you.
Thank you. Okay, I'm very happy to be talking today about the Queer Futures 2 study, which is an NIHR funded study that was funded under the call for research into what actually works to improve LGBTQ plus young people's mental health and other people's mental health. So although it's a 3-year study, it was extended by a year because of COVID. And this is the first time I've tried to tell the whole story of the research. So you might have to bear with in terms of I haven't smoothed out some of the complications, I think, in recounting what we did and what we found. We're nearly there. We're nearly complete. So I'm going to talk about what we found so far that works to support LGBTQ plus young people's mental health. And also the slide, we're kind of experimenting with slides. So the slides I'm going to show you, the ones that are got lovely graphics on and are all kind of funky. Those have been designed by our fantastic Queer Futures project administrator, Shelley Watson, who I think is on the call. And the ones that are really boring and just text will obviously be the ones that that I've done. So I'm going to try and get through this in about 30 minutes, hopefully. So this study is. So I'm going to start with some background, basically, because I'm not sure who's on the call and what people know about LGBTQ plus young people's mental health. So, excuse me. We're really, for about the last 30 years across the Western world, we've been producing evidence around prevalence rates that consistently show that LGBTQ plus young people have higher rates of depression, self-harm, suicidality, and poor mental health. And we've been doing that for quite a long time, and those higher rates are consistent across different countries, different time spans, and in fact, different diagnosis also. So much so that we've got some quite substantial evidence now that has shown that the prevalence rates are higher than you would expect in comparison to cisgendered or heterosexual youth. So we've got a pooled analysis that Semlin and colleagues did of 12 UK population surveys that show that lesbian, gay and bisexual people under the age of 35 in the UK are twice as likely to have poor mental health in comparison to cisgendered or heterosexual people. Similarly, a recent meta-analysis showed that we're looking at attempted suicide, showed that compared to cisgender and heterosexual youth, trans young people were 6 times more likely to have attempted suicide, bisexual young people 5 times, and lesbian and gay 4 times more likely. So this is consistent. So we know that the issue is serious, and as the mental health condition becomes more serious, the disparity between LGBTQ young people's rates and cisgender and heterosexual youth widens also. We also now started to accrue longitudinal evidence, and this is an example of a UK study, the Avon, which is a Bristol-based longitudinal study. And you can see on the bottom, on the horizontal axis is age, and on the vertical is the score from the short mood and feelings questionnaire. So that's increased or worse mental health. You can see that the blue line is heterosexual, and those that identify as heterosexual, and the red line is those that identify as a sexual minority. And already at the age of 10, there is a disparity between those two groups, and that widens as over time towards 17, 18, and then around 19 it starts to close a little bit. So longitudinal evidence is showing that this differential between LGBTQ young people and cis and heterosexual young people is present at quite an early age. We also have consistent evidence across the globe around what those risk factors are. So why it is that LGBTQ young people might have higher prevalence rates, and those are I've crudely grouped these into experiences of homophobic or biphobic or transphobic victimization and discrimination, so from family, peers, in school, etc., etc. Another group of risk factors is being unable to disclose your sexual or gender identity, or some people might know that as being in the closet. Cis heteronormativity, and that what means that really feeling that you don't fit into the norms of society. So kind of more subtle than just victimization or discrimination. Identifying as LGBTQ plus at an early age is also a risk factor. Gender atypicality, social isolation, and conflict with family or peers about sexual and gender identity. So those are sort of big risk factors that, again, are consistent over time and over geography. What we know much, much less about is what young LGBTQ people do when they feel they want help with their mental health situation, and also what it is that improves mental health, or what kind of support and services might be effective for that group of young people. So the evidence that we do have in the UK anyway has been produced through the first Queer Future study. So the Queer Futures 2 study, what works is, which I'm going to present, is a second study. And the first one, which actually looked specifically at self-harm and suicide in LGBTQ young people. But one of the features of this study was to look at how do young LGBTQ plus young people look for help, and what kind of experience of services do they have. So this was a mixed method study and had interviews and a survey, an online survey. So I'm going to show you a couple of slides from the online survey, which is about 800 participants, and it was a community convenient sampling. And you can see here, we wanted to know, I can't see this, it's really annoying because the Zoom thing is right above me, but right on my slide. But this is who we asked young people, who did they ask for help when they were beginning to worry about their mental health and felt they needed help. And you can see up the vertical axis is all the different categories of people they could have asked, and along the horizontal is the percentage of the sample that asked for help from those people. And you can see that half the sample, the long at the bottom, asked a friend or the internet. Nearly a third went to the GP for help. Worryingly, a fifth of the sample didn't ask anyone for help. A similar fifth asked what used mental health services, and then you can see the kind of diminishing. So internet and friend being most widely used, and concerningly, that a fifth of that sample didn't ask for help at all. So we suspected this might be the case, and we wanted to know why it is that they didn't ask for help when they had mental health problems and felt they needed help. So you can see that I think that's nearly 50% of the samples said that they didn't ask for help because they didn't want to be seen as attention seeking. Again, 43%, I didn't want people to worry about me. So then nearly 40%, I felt ashamed of my self-harm, suicidal feelings. I thought my family would be disappointed. I didn't want to be judged. I thought I would not be taken seriously. And a quarter there, I did not want anyone to know about that says sexuality and gender. I couldn't on the slide. So you can see a kind of whole raft of reasons there that are tied into, in terms of, you know, my interpretation around this is being young. So that attention seeking, feeling like they're not going to be taken seriously, that their emotional and mental health difficulties aren't going to be taken seriously. And probably counter to our stereotypes around young people and teenagers being selfish. They were concerned about not worrying others, being ashamed about their self-harm, suicidal feelings. So that stigma of mental health again rearing its head, and also this not wanting anyone to know about their sexuality or their gender diversity. So kind of quite a complicated nexus of reasons that were present in that study. We then asked, okay, for those that did seek support, what was helpful? And also, this was only those that, this is from the sample that actually sought help. So you can see on the left-hand side of that screen that those that sought help from an LGBTQ specific youth group, 3/4 of them found that helpful. Again, 3/4 of those that used the internet, which was the majority, for help, found that helpful. 3/4 found their friends helpful, and then kind of diminishing helpfulness in terms of those that asked their boyfriend, girlfriend, or partner, or parent, or carer. And then when we get to GP and NHS Mental Health Services, you can see that really only half of the sample that accessed those services found them very helpful. So quite crude kind of indicators of that. Overall, this group of young people, and there's pockets of research elsewhere, underutilise mental health services despite perhaps the greater need. There's a tendency to access them at crisis points, so it's not just this evidence but elsewhere, and that when they do use mental health services, their experience is not always very good or very, very helpful. So in the Queer Features 2 study, what we wanted to try to do was look at an earlier point, so not wait until people got into crisis situations in terms of suicidal feelings, etc. And so this study was set up to look at what kind of support would work at an earlier point, so in early intervention for common mental health problems. Again, this is funded by, I think I said this now, the NIHR. So really what we were trying to do is work out what works best for supporting LGBTQ young people between the ages of 12 and 25, so quite a wide age group with common mental health problems. And the study was 3 stages. First of all, we did a systematic review, like all good researchers. Then we did a service mapping exercise. I'm going to take it to say a little bit about those, where we were specifically looking for LGBTQ plus specific mental health support across the whole of the UK. And then lastly, we did and are in just about finishing a case study evaluation to see what works. Throughout the whole study, we had LGBTQ young people involved. We still have young people involved. So we have someone on the research team, and we also have an advisory group that we work with and we're currently working with to develop the outputs. So I'm just going to say briefly about those 3 things. So in the first stage in this systematic review, we actually did what was called a meta-narrative review, which is where it's a theory-led way of doing a systematic review, and it's often used where you've got very heterogeneous sets of literature from different disciplines. So you're trying to make sense of what's being found across different disciplines using a theoretical approach. And you can see in this is the model that we came up with. So this is just from existing research literature. And I gave it a very jaunty title of Theoretical Non-Pathologizing Framework for Providing Mental Health Support to LGBTQ plus Youth, which isn't very catchy, but hey ho. And so that's what's happening there in that model is the outer ring is kind of like those macro type norms and power dynamics that influence mental health and service provision that we need to think about when we're providing support for LGBTQ young people with mental health difficulties. The second layer of that model is really a kind of meso level, so it's the overarching characteristics that the literature suggested effective support should emulate. The third third layer there is kind of individual characteristics of support, and the fourth in the middle there is the different ways that kind of is trying to indicate mental health. And because we were talking across or working across research from different disciplines, that the conceptualization around mental health was quite broad, so we left that broad. If you're interested in that paper, you can find it for free on Social Science and Medicine, the mental health version, and there's a link there. So this is what this is what we came up with in terms of what we thought what the existing research literature told us might work to support LGBT young people. What we were going to do then is take this model and use it to test in different services and work out whether or not actually is this the right model? Are there examples of services that are doing things differently? So then in the second stage, what we had to do is find services that we could use this model in a sense to test in those services. So we did, I forgot this slide, yes. So there are three kind of consistent things that were really strongly have remained throughout the this whole project arc, that we knew that, or that consistently seemed to work to support mental health. One was this idea of belonging, that a service, LGBT youth need to feel like they can fit in the support service, that it's for them, it's non-judgmental, inclusive, encouraging a kind of coping and trust. Something that we've called relationality, which is about the importance of connections to peers and trusted adults, and that there was certainly a theme of literature that suggested that this was more effective at reducing poor mental health than perhaps other more conventional support services, or support services, and also the importance of recognising for LGBTQ young people there are often family difficulties. And then recognition was also a characteristic that seemed to be consistently supported across the entire study. And by recognition, what we mean is the affirmation of gender, that support services needs to affirm gender and sexual self-definition and foster a positive identity where the individual is understood and accepted. So those were in that model I just showed you and have been kind of consistently present throughout the study and what I'm going to talk about. So we then moved to a mapping exercise where what we were trying to do was find services, mental health support services that had specifically adapted some part of their service to address LGBTQ young people. So we were looking for something that was beyond just a policy. We wanted something that had service that showed evidence of understanding that LGBTQ plus young people were less likely to ask for help and needed specific provision. And we did that across the UK, Northern Ireland, Scotland, Wales, and in the end we ended up with about 111 specific services. And what I've written here is just kind of a characterization of those services. And first, we found that the majority of LGBTQ plus specific mental health support was in voluntary organisations, so the charity sector. But there was, interestingly, an emerging service model where those voluntary organisations or community organisations were collaborating with CAMHS to try and find a way of mainstreaming their services a bit and making them more widely available. What we also found was a distinct absence of mainstream NHS support that had adapted and specifically addressed LGBTQ young people. And also what we found was a very distinct difference in the approaches of the services So those that were provided in the more voluntary sector had as pivotal, as central to the service, the affirmation of LGBT identities, so the recognition of them and how important that was. And that too often in CAMS and in mainstream NHS services, there was an approach which was treating everyone the same. So, you know, the response we got was, no, we don't make any distinction between young people, we treat everyone the same, which we know doesn't work in terms of equality. So that was kind of the overall mapping exercise. And just to say a bit more about why we thought, because we had a lot of interaction with a lot of people around CAMS provision and other sorts of provision, why there is such a kind of lack of understanding around LGBT young peoples, and hence why there seems to be a lack of mainstream NHS specific provision for this group. And that was, we think, around 4 factors. That basically it's generally not understood that there is a heightened risk of poor mental health in LGBTQ plus young people, that there's a misunderstanding about the reasons for those higher rates of poor mental health, that it's not understood that there's underutilization of mental health services, and also that when young people, LGBT young people, get into those services, not always a very good experience. And again, if you're interested in that mapping exercise, there's a free publication that's in the British Student Doctors Journal there, that you can access the links there. Okay, so we mapped these services, then we formed this typology of different types, like education, in the voluntary sector, community sector, local authority, NHS, and so we chose 12 case studies from those services to carry out a case study evaluation, which is a theory-driven type of evaluation. I could do a whole presentation about how we went around purposely selecting those, but you might want to ask me, or you may not, in the questions. So for each of those 12 case studies, we collected data through WhatsApp interviews with LGBTQ young people. So basically, we had just negotiated access with these 12 different service types, which was quite a lengthy and carefully negotiated affair when the pandemics hit. So we had to, like many people, we were doing a lot of this face-to-face, have to go online. So we collected from each of the sites, services, WhatsApp interviews with LGBTQ young people. We did Teams interviews with family members and service staff. We did a whole documentary review, so looking at policies and practice, the website design, all sorts of things about, where there was a website, about the service. We did something we called ethnographic observation. So there was a lot of conversation, discussion, observation about how those services were running through the pandemic and online. And we also did a service use survey, which was about, in the end, understanding the costs of different service provisions. We then conducted a 4-phase explanation building data analysis strategy, which is both deductive and inductive for those who are interested in these things. And basically what we did is use the findings from each of the case study sites, so each of the services, to refine that original what works model. And the aim of all of that was to try and produce an understanding of how, why, and in what context mental health early intervention services and self-care actually work for LGBTQ young people. So basically we were doing this. We went from this model that was produced from the empirical research about mental health support services to trying to adapt that, given that we were not adapted, we were testing that. So what was present in those different of 12 services that we used to sample, what was missing, what needed to be adjusted, etc. And so we did that through a data analysis phase, and we came up with this interim youth rights model, and that model is very sophisticated flip chart. There's a picture of it there, and post-it notes. So that that data and that sort of move across into a youth rights model was through the first 3 phases of the data analysis strategy. We were also heavily influenced by the WHO guidance, so the WHO guidance on community mental health and rights-based approaches. We were also influenced by the way that the UN Convention for the Rights of the Child was being used within some of the services that were providing mental health support. The UN recognition that young people are often forgotten group in the UN human rights system, and also during the pandemic and the emerging recognition of and concern about the mental health effects of the pandemic on young people, and the UNICEF have written a position paper called The New Normal, which is about the right to best health services possible, which is in the Convention on the Rights of the Child, but the importance of including mental health in that. So, so we had this interim model, then we went into our last phase of our data analysis and produced these key principles of a youth rights model. I can't see that top strap line because I can't get the bar down. Never mind. And so we started to include some things that weren't in the original model that was made from the empirical data, you can see. So we've got things there that, and I'm going to just go through these quickly, not on this slide, but things around the body, things that you probably wouldn't expect to see in a mental health support description of a mental health support service. Space, time, the importance of having a critical mental health approach, so a non-pathologizing around emotion, importance of stage, age, importance of professional relationship work. So all sorts of things that were coming out that we were bringing together. And this is where we're at. This is our draft model that we are using, which we're calling an intersectional youth rights model for supporting mental health LGBTQ young people. And in a few minutes, I'm going to explain this to you. So this is draft because we are taking this out to consult with different stakeholders. We're doing a series of validation exercises just to really plug the gaps that were left by COVID. So stuff that we weren't able to do. So in particular, some work with Scotland and Wales, and also young people, and some various aspects of young people that we want to just ensure that we're hitting the right spot, kind of thing. So this is an intersectional youth rights, and what we mean by that is, in terms of intersectional, what we're saying here is that yes, you must, as any support service for LGBTQ young people's mental health needs to have as pivotal the recognition of LGBTQ plus identities, but actually those identities are not homogeneous. They are affected by all sorts of other dynamics, such as ethnicity and disability, etc. And that is fundamental to the ways in which we ought to work with effectively with young people in mental health. Youth rights, because really what came through very, very strongly from the data was the importance of young people being able to have a view and be listened to around matters that affected them, and that this seemed to be absolutely central to effective LGBT mental health support. So on the outside of that model, there are these people and relationships, the body, space and time. So these are all facets that are actually enable those concentric rings in the middle there to happen. So relationships all the way through, we called it relationality, we called it professional relationship work, we called it, but it was seen to be absolutely central to providing a kind of service for LGBT young people, particularly around addressing isolation. but actually providing those key relationships with staff and peers and volunteers, that trusted adult. And also what came out as quite important was intergenerational and community connections. So the importance of all of that. Time is a really interesting facet of the service provision, because we know how pressed people are for time. We're aware of those kind of issues around waiting times for CAMs. So that was very important in the type of service provision that was effective, particularly from young people's point of view. So it wasn't just about waiting time, it was about the frequency of being seen, how long you were seen, the timing of the support where you were, having a rapid response, having time to build relationships, the pace of that, the journey time for young people, being in as much as possible in youth time rather than adult determined time. So that was very, very important to young people and actually service providers. Similarly with space, you know, for young people, space is their space they occupy are very adult defined, aren't they? School, home, its space is usually controlled by adults. It's places where young people are surveyed, and normally in space that is designed by adults. And it was very significant across our data set that young people and the service providers talked about the importance of having physical space that was young people defined, but also emotional space. So again, that's got a time implication to it, and social space in the way that everything was delivered. Also, the body was very important in terms of sleep, nutrition, activity, the mind-body interconnection. And for LGBTQ young people, the body is a site of the kind of expression in terms of sexuality and gender. So that being very important to be aware of in terms of the service. And those rings in the middle there are, I think you probably, they're not, wouldn't be a surprise to you, but safety being very, very important to this group of young people who often feel unsafe where they are, in places where they should feel safe, and are fearful. So how safety is addressed in the service is very, very important. The young people need to feel that they have utter confidence in confidentiality and anonymity, privacy, and there isn't a presumption there, and that's defined by young people rather than adults. Agency, and I sort of talked a little bit about that young people have to be facilitated and helped in order to be able to be the drivers in the sense of their own mental health support. And we've got here possibility, and this was really about how in our data set from the service providers and from young people and indeed parents, that an idea of the future was very important to young people, LGBT young people. When you stand outside of norms, being able to see what it's like to become older or become an adult was very, very important. I've talked about recognition, and that's very much about utilizing LGBTQ identities. So, you know, this is understanding there may be difficulties and helping young people overcome those difficulties in terms of because of their identity, but also with an understanding that those identities are fluid and flexible, and that service allows young people to move around, change their mind. You know, we don't like people changing their minds, do we? And that there's not necessarily a fixed kind of destination for them. Belonging, again, you know, that's inclusion, part and parcel of what seemed to work in the data. And emotions, that young people and service provider talked a lot about the different ways they talked about emotion, they utilized emotion, they how to deal with difficult emotions, that kind of not assuming that the certain emotions were connected to particular things, and it was very young people led. And you can see on the left hand side of that slide, there's we've used feelings that came up in the data and we call them, they're kind of like nexus points, so they correspond to those blue overlapping star points, 1, 2, 3, 4, 5, where if a young person, if the service is doing well, the young person, for example, will feel respected rather than dismissed. And if they're feeling in control, if the service is doing well, they feel in control, or they're being facilitated in and feel listened to be in control rather than powerless, etc. So this is where we're at, and I don't think I've really explained that very well, and that's partly because what we're doing at the moment is taking an enormous great data set, which we've worked with this very elaborate data analysis strategy, and come up with this model. And now what we're doing is slowly coming out of that, trying to articulate it for different audiences, and we're working in these validation exercise activities to work with different stakeholders, so clinicians, mental health commissioners, young people, the voluntary sector, youth workers, etc., to be able to articulate it better than I think I've probably articulated it today. So that is where we are. That is what we think works to support LGBTQ plus young people's mental health. And we've got another, I don't know, 9 months, I think, to do that process, to produce the outputs. We'll be producing NHS Commission guidelines and outputs for young people in the sector and various things. And if you're interested in any of those, they will be available via website, and we'll be doing some webinars, etc. So you can sign up for the Queer Futures website, or you can follow us on Twitter. Right, I think I'll leave it there because I've gone on longer than I should have done. Apologies.
That's fantastic. Thank you so much, Liz. That's really great. Thank you for the excellent talk. So we have about 10 or 15 minutes for questions. So feel free to put in the Q&A box. Apologies for me talking about the chat earlier in the introduction. So post in the Q&A. I've got 2 questions to start off with, and one in my head. So I'll go to the colleagues who've put questions in the Q&A already first, Liz. So one from Maria. Thank you, Liz. Can I ask whether you found the help-seeking pathways of LGBTQ plus young people who self-harm to be different from those of heterosexual young people who self-harm?
So that in that study, the sample was just with LGBTQ plus young people, but we used in the question all of Keith Horton's work, etc., for all the different reasons that young people don't seek help for self-harm, but we included other options that were informed from the qualitative data stage of the study that we did previous to that. And so those issues seem to be much more around sexuality and gender, being, not wanting to people to know, but lots of the other things not being seen to be intention seeking, etc., are similar to all young people. Actually, it was mainly around the sexuality and gender that was the issue.
Super, thank you, Liz. And a question from Naya. How do you think learnings from the mapping exercise in relation to services can be applied to mental health research and public and patient involvement activity? I guess whether there's any kind of follow through or generalization from the mapping in the one arena to the other, Liz.
Yeah. I just think, we did a freedom of information exercise to CAM services across the UK to try, because we found it really difficult to get information from those services, and we just met consistently with not either two things: either we don't need to do this, we treat everyone the same, or we would really like to do this but we can't, or we don't know how to, or we can't because of operationalized stuff, or their hands are tied, or they're so busy, or all of those things we know that are affecting the NHS. But there were a couple of places where CAM services have been fantastically innovative and had involved young people. So there was one example, I think it was Herefordshire, where they had young people involved in training CAMHS practitioners around how to talk to LGBTQ young people, what the concerns might be, all of that kind, which was fantastic, so where I think there was I think that was driven by someone who had a specific equality hat, was given time and resources to do that. So I think in terms, particularly mainstream services, I think, that there is definitely, people want to do something because they recognise that there is an issue here, but they either don't know what to do, or it just seems impossible in the current climate, in the current way that CAMHS services are running. Does that answer the question a bit?
Yeah, I think so. I think Niall also asked about how it might link to sort of PPI, perhaps, Liz.
Yeah, I mean, do you mean, I'm not really sure if I understand the question. Do you mean was PPI involved in the mapping exercise, or I'm not sure. I mean, there was PPI throughout the whole study.
I suppose one thought, well, I mean, maybe now I'll jump in if I'm mischaracterizing his question is, but my thought was wondering if the learning from what LGBTQ plus people want from mental health services, can we also help our PPI adapt it in that way to make it more accessible and friendly and useful for them? Right.
Yeah. I mean, there was lots. I mean, basically, the best services all had LGBT young people's input into that service provision, and often there were a group of services that were youth mental health support, and they might be in local authority or voluntary sector, but they had an LGBT specific service arm, if you like, and that always had lots of all young people involved in the provision of that service.
Great, thank you. And now put a clarification up there, Liz. So I'll read it out for the audience, but you can respond obviously in a moment. So Naya says, I was more relating to how practice should be changed in regards to not generalizing all young people and treating everyone the same.
Yeah, completely. Having young people involved in the design of the service was absolutely key to the success of some of these, and some of them went out, had designed whole buildings with young people, and also, the timings of things, all sorts of things. So where young people were involved, that definitely was a marker, usually, of understanding that young people, in this case, LGBT young people come in all shapes and sizes. One of the failings of the services, though, was there was not enough recognition of how the role of ethnicity. So that was an area that was lacking, that we're drawing attention to, really. Yeah.
Thank you. You've touched on it a little bit, actually, Liz, in some of your response already, but my kind of question was twofold about really the sort of baseline knowledge of practitioners sort of now. I'm wondering how confident they feel about talking about these topics, how much knowledge they have, whether they feel able to ask questions about it even. I guess I attended the Youth Mental Health Conference, and it was really helpful to me just having a plenary speaker talk about some of this, actually just go through the vocabulary and concepts with the audience was really helpful. That was one thought I was going to ask. And the second was, given that CAMHS, as you say, it's quite hard maybe to get much change happening given the constraints, has your work been picked up by sort of third sector, private healthcare, universities, I guess other kind of care providers for young people's mental health?
Okay, so in terms of the practitioners' confidence, that's absolutely right. So in the first Queer Future study, we did a mental health practitioners survey just to really assess that kind of confidence, and it was absolutely clear that those practitioners that had training around LGBT inclusivity were more confident about talking to young people about their sexuality and gender, and were indeed more likely to do it. So that's absolutely, and there's lots of the service providers actually did training in their locality with practitioners, and some of the best examples of that were, like I said, LGBT young people training people, but also the local, so third sector organisations training GPs and all sorts in terms of being able to talk about those kind of identity issues. So it is definitely, and in the 20 odd years that I've been doing this, 25 years, the field has moved from, you know, people not recognising that it's a problem that LGBT young people don't use mental health services, are not likely to actually, we found in doing this study that people they want to do something about it, they just don't know how or don't feel confident about it. So it's a kind of a very different situation. And oh God, I've just put CAMS as the second question. I can't remember what the second question was now, Matthew. Sorry, what did you say?
Sorry, Liz. So thinking if NHS, obviously the pressures and constraints it's under, whether third sector, private health providers, university, sixth form, these kind of colleagues may be able to adapt the way they're working.
Yes, yeah. So so one of the case studies in the study was a further education college. We found it very difficult to get any information about LGBTQ+ in education in schools, actually. So, but I know that it does go on in there, and that kind of support goes on. And there were certainly instances of where a couple of very important instances where there were collaborations between third sector and CAMS. So CAMS provision was either put into charity in a sense, or services were commissioned at a local level for services from the actual organisation, the third sector organisation. So there's definitely that's part of the recognition, I think, that actually it may not be the right place to have those services in CAMS. I think that's kind of, it's not clear where's best, where delivery is best placed, I think.
Yep. Thank you, Liz. And our last question before we close, but a question from Lucienne. So thank you for the brilliant talk. I was wondering if you could expand a talk on how you made the youth rights model intersectional. So some comments and reflections on that, Liz, if possible.
Yes, so the intersectionality, we started to incorporate that really from the point of the review, because that was something that we thought theoretically was important, and it was also in the literature. So our approach on intersectionality is this idea that, like I said, that, you know, being LGBTQ+ is not homogenous. You know, people are you know, lots of different positionings. And also we think of it in terms of marginalization and privilege. So recognizing kind of white privilege and other privileges alongside just how marginalization can work across different types of power dynamics and sites. If I was to start talking about how we made the youth rights model intersectional, I'd have to go back to, so we wrote a position paper, a theoretical paper, we incorporated it through, so questions about intersectionality that went through all of the data we collected. So that meant looking at the documentary review, looking at asking practitioners and young people, specifically making sure that the sample demographically had all those different kind of intersectional points in there. So making sure there were disabled young people, also trans and non-binary young people, people from different BAME young people. So that making sure that diversity was in there. And we took it as a central plank to what we were doing in the analysis. So, and at the endpoint with that model, we are specifically going to do some activities, some verification activities with those workers that that work with Black and minority ethnic LGBTQ young people. So we call it in the trade QTPOP. And also with QTPOP young people themselves, just to kind of make sure that, try to bolster in a sense the way the model is intersectional, because one of the things that we found lacking was there was a tendency with the services to have an approach that not all of them, but the majority of them, that the LGBTQ plus was this kind of homogenous thing.
Super, thank you very much, Liz, and thank you, Lucian, for the question. I think you've gone through the questions that's been asked, Liz, so I'll thank you for a fantastic talk, and thank you to the audience for some excellent questions, sort of bring out some of the themes of that. I look forward to hearing about how this important research develops in future, and I guess your leadership of the Institute for Mental Health and the inequalities work we're carrying on more broadly in our work with the Youth Advisory Group. So thank you very much, Liz, for that, and thank you for the talk.
Thank you for listening, everyone. Okay.
Yeah, cheers. And the slides there from Liz about how you can sign up to hear more about her ongoing work. And thank you all, and I'll close down the Zoom now. Cheers.
Bye.
Bye. Thank you, Liz.